primarily specialize in working with children who have high-functioning autism spectrum disorder, ADHD, and anxiety. And then in addition to my clinical role, I also have a research and teaching role through this. So the objectives for our discussion tonight is one, to increase understanding related to the function of behaviors. So what's the purpose that you're seeing certain behaviors in your child? Learning strategies to manage hyperactivity and impulsivity in a home setting, as well as coping strategies that you can help prompt, coach, and reinforce in your children, and then also some strategies to minimize the impact of these symptoms on academic functioning. So it's important to start off with understanding both differential diagnosis, meaning sometimes other disorders can look like ADHD, as well as comorbidities, meaning that some disorders are diagnosed in addition to ADHD. And so on this slide are the most common comorbidities or disorders that we have to think about a differential diagnosis. So for example, with anxiety, someone may have difficulty sustaining attention and may be restless, and that could sometimes be confused as looking like ADHD. Or there could be a comorbidity there, that someone does have generalized anxiety and has concerns or worries about academic performance or in other areas. Autism spectrum disorder, certainly there's some overlap. And now with the DSM-5, we can diagnose ADHD along with autism spectrum disorder. And the overlap there would be executive functioning deficits, and also there could be restlessness, pacing, so that's something else that there may be a comorbidity. Adjustment, if a child has just gone to a new school, has moved, there's been a change in the family dynamics, we want to give it a period of time because it's not uncommon that you may see some externalizing behaviors that could be attributed just to adjustment alone and not be ever accounted for by diagnosis of ADHD. Trauma, certainly. So we often see in trauma hypervigilance, which looks like hyperactivity. And then there could be a language or a communication disorder. So if a child has an expressive or receptive language deficit, then they have difficulty maybe communicating with other people or understanding others. And so sometimes that can cause or contribute to hyperactive impulsive behaviors. Bipolar disorder, most often, although it is rare, a child first gets a diagnosis typically of ADHD before bipolar disorder. And that's usually because of the hypomania piece that can be confused with hyperactivity. Sleep problems alone. So if a child does have sleep deprivation, that can cause inattention, restlessness. It could also exacerbate ADHD symptoms. So if the diagnosis is already present, it could certainly make that worse. So we always want to make sure the sleep is taken care of first so we can really see what we're working with. And then prenatal exposure, so meaning to alcohol or other substances. So that could also be comorbid or a result connected with ADHD. So in general, as you all know, ADHD is considered a neurodevelopmental disorder. And with the DSM-5, symptoms can now be classified as mild, moderate, or severe. And so essentially what it means is ADHD, there's not enough chemicals called neurotransmitters in order to help the brain kind of control behavior or control functioning. And we also know that, based on our studies, that there tends to be lower less brain volume in children who have ADHD. And there's also the prefrontal cortex, so a part of the brain is less active in comparison to individuals who don't have ADHD. And then there's also the genetic component that we consider. So if there's a first-degree relative who has ADHD, then 25% of those children will have ADHD as well. So we want to consider and get genetic information, environmental information too, lead exposure, those types of things, and then certainly what's going on currently in the environment. And 5 to 10% of children, studies vary a little bit, will meet criteria for ADHD. And boys are 3 times more likely than females to receive a diagnosis of ADHD. So here are some common examples, and I'm sure you're all familiar with these examples. So these we would say are some of the hallmark features in terms of hyperactivity and impulsivity. But there's also a lot of secondary features that we find in working with children, so more anecdotally. And so some of those would be poor problem solving. So in terms of thinking about their behavior and the consequences their behavior has, or working on social conflict with other children, that's an area that there tends to be some difficulty. Sometimes respecting personal boundaries, so entering into others' personal space. Silly or inappropriate behaviors. We tend to see more emotional outbursts, so more tantruming, or difficulty regulating emotions. And we also tend to see, in general, that there's just more peer challenges and certainly challenges within the school environment. So the younger the child is that does get a diagnosis of ADHD, the more likely we see or hear of there were detentions, suspensions, expulsions. So those are all like red flag behaviors that we certainly want to assess for ADHD. About 30 to 50% of children who are diagnosed with ADHD will meet criteria in adulthood as well. So it's not that a neurodevelopmental disorder goes away, it's that these individuals learn coping strategies and behavioral strategies to manage the symptoms, so it no longer reaches clinical impairment, meaning that it's no longer disturbing, significantly interfering with day-to-day functioning. We know that stimulant medication is 5 times greater than what it was in 2002 in terms of use of the medication. And 3.5 million children, roughly, are on stimulant medications currently. So after the diagnostic picture has been determined and we have impressions, then we move into a treatment plan. And so we work with families on identifying what are the goals. So what are the goals at home in terms of social functioning, academic functioning. And where I always start is determining what's the function of certain behaviors. So the question that I often get in the office setting is what's what? So if a child has, for example, anxiety and ADHD, or has been diagnosed with oppositional defiant disorder, ODD, and ADHD, trying to figure out which is what. What is the ADHD and what's, quote unquote, willful choice? So I work with parents on what we call the ABCs, and that's kind of the foundation of behavioral therapy or behavioral intervention. So some of you may already be familiar with that. So the ABCs. A stands for antecedents, so triggers, the actual behavior that you're seeing or the targeted behavior, the behavior of concern. And then the C stands for consequences. Not meaning from a punitive standpoint, but it stands for how do other people respond to the child when the child exhibits that behavior, and then how does the child respond back. So looking at that relationship. That helps us then determine what's the purpose of the behavior. When we understand what the purpose is, then we're better able to treat it, we're better able to address it. So this piece is super important. So I always get this information from parents, and then oftentimes we get it from the school as well. Some of you may have heard or be familiar with FBA, functional behavior analysis, and that often is built from the foundation, our ABCs, the antecedents, behaviors, and consequences. So just some examples. So to avoid or escape a behavior or a situation, that is something that's one typical function of the behavior that we often see. And so if it's avoiding or escaping, and we know that the trigger is something that's anxiety-provoking for the child is just trying to avoid it to maintain safety or to avoid distress. Sometimes if the child's having difficulty in school, it's simply because the task is really, really hard for that child. And so then you see a chronic pattern of maybe getting up and leaving the classroom, for example. And another important piece to note is that 50% of children who are diagnosed with ADHD will also have a learning disorder. So it's really important that we stay on top of understanding their academic functioning and how that plays a role. So those are just a couple of examples of the function of the behavior being avoiding or escaping something. Sometimes it's to obtain something tangible, so they want to play video games all the time, or there's something that they want to have access to. And so in that case, they often have difficulty delaying gratification. So the thought comes to mind that that's what they want to do it then and there, and it's hard for them to wait. So what we do is we work on building that behavioral plan of how can you earn the thing that you really want. So once we understand that that's the piece that you're engaging in behavior to get something, then we can identify how do we work and show adaptive behaviors to get that thing that you want. Just a basic need being met, so they're hungry. And then sometimes sensory overload. So just being overly stimulated and can be the functional behavior. So meaning if they tend to act more disorganized or chaotic in a certain setting, it could be just that there's too much stimuli. And so we've got to reduce some of that by time or just make environmental modifications. We often say that a three-pronged approach is recommended for a child who has ADHD based on our research. So we would say these are evidence-based strategies, meaning that there's enough documentation and enough studies that have been done to show support for all of these pieces. So the first being parent training. Parent training means that we work with parents on creating essentially a behavioral plan. So, and I'll talk about this more later, but what are the behaviors that we should reward at home? What do we ignore? What do we give consequences to? I've never met a parent who's come in and said, I haven't tried anything. Like, everyone has tried something. And sometimes it's simply just us working as coaches and working as part of your team to figure out, okay, it's the timing. It's the way that this sticker chart, for example, or it's the way that this plan is being implemented. So you'd be surprised how just minor tweaks can make a big, big difference. So that's the bulk of parent training. Behavioral therapy is more in reference to working one-on-one with a child. Now, certainly the child has to be old enough, right? And we're thinking more about behavioral and emotional regulation, self-monitoring. And again, I'll address that a little bit later. The second piece is classroom-based accommodations or modifications. So some of you may be familiar with a 504 plan at school, and so sometimes children qualify for a 504 plan, which means that they're getting accommodations. So meaning that they're trying to decrease barriers to learning in the classroom setting that are associated with ADHD. So an example would be getting extended time on a test or being able to take a test in a quiet environment. And then we have the IEP, the Individualized Education Program or Plan. And that means that there's specialized education, so like a modification to the curriculum needs to be made. And with the IEP, there has to be measurable goals that are identified. And the 504 plan doesn't have to have that. So annually, though, the 504 plan, the IEP are revisited, but the IEP has the specific goals. And then certainly medication management.
So the special education process diagram is very helpful, and that's on the CHAD website if you're looking to find more information about that. And then certainly the last piece that's an evidence-based intervention is medication management. The largest study that was ever done looking at ADHD and results and outcomes based on treatment is known as the multimodal treatment study of children with ADHD, otherwise known as the MTA. And results were actually first published in the late 90s, early 2000s. And so it's been around for a while. And then they continue to collect data. And so what we know is that combined medication and behavioral treatment, so behavioral treatment meaning parent training and behavior management and or behavioral intervention, work better than each of these interventions alone. So if someone is coming into my office, I always provide kind of the information of what the research shows. Medication alone does work significantly better than behavioral intervention alone or treatment as usual. Now, certainly there are always individual situations where that may not have been the case, but this is just an overall trend.
So this is an outline of parenting strategies. So the parent training and behavior management that I was referencing before, these are the main components. Some I'll address on this slide, and some I have separate slides to go into more detail. But the first thing that I work with parents on is labeled praise. So telling the child specifically what he or she is doing a good job at. So you're doing a great job walking quietly, or I love how you're staying seated while you're completing your homework. Oftentimes we give praise, but we just say, great, good job. Well, a child doesn't know what is it really specifically that I'm doing that's so great or that I'm doing a good job at. The more specific you are, that's going to increase the behavior you want to see. Okay? And so we know that the most effective way to change behavior is through reinforcement, meaning praise and offering a reward, something tangible. So we know that this works. And so I just work with parents on identifying, okay, how can we be more specific about the praise? What are the behaviors that we want to see? And so let's make sure we praise those. And sometimes we do what I call praising the positive opposite. So meaning if, for example, the child always runs in the house and is climbing on furniture, as soon as that child gets in the house, the child can't be running. There's a second or two that child is walking, or a second or two before that child's jumping on the furniture. So you say, you're doing such a great job using your walking feet. I love your walking feet. Again, because people are motivated to get attention, and for that positive attention is really, if you have to choose between positive or negative, the children and everybody would want positive attention. So that's one area that we do address. Oftentimes what ends up happening is children with ADHD get corrected so often, so they get lots of negative feedback. And what ends up happening is, unfortunately, sometimes the developmental trajectory, meaning that the next phase is when ADHD isn't entirely managed, then we see oppositional defiant disorder start to present. And it's just because that child is so accustomed to negative feedback that their self-esteem has been affected, and it doesn't matter anymore. So attention is just attention. So we want to get away from that, and we want to shift the balance. So more positive, less negative. We also address special time, and I'll talk about that a little bit later, but we recommend that a parent spend 5 to 10 minutes individually with a child each day, and that's a purely positive time where it's child-directed and the parent avoids questions, criticisms, commands. Usually, what ends up happening is if there is a time when we're interacting, we're trying to get information about the day, how things went. And so then usually what happens is the child clams up, gets angry or upset, and then what was supposed to be a purely positive time to promote that positive parent-child interaction has been kind of ruined. So that's why we stay away from that. The reinforcement plan, so what are the behaviors we're going to reward? Talk about that. Of course, setting clear expectations. The child really needs to know what is expected of him or her in every single setting. That child should be able to tell you the rules at home and at school. That's one of the questions I always ask. And they need to know when they do X behavior, whether it's positive or negative, what's going to be the outcome. How are people going to respond? And they tend to do better with structure and positive discipline strategies, and when we provide social and emotional coaching. And I'll talk about these. So the reinforcement plan, also sometimes known as an incentive system or token economy, referred to as different things. The first step is to identify the behaviors to reward. So what are the behaviors you really want that child to be exhibiting? Maybe it's completing a certain task within a period of time. Maybe it's getting ready in the morning with 3 or fewer prompts to brush teeth. We want to make it as specific as possible so we can measure it to see if they determine, to see if they've met that goal. And they should be able to know if they met that goal. So any objective way we can measure it, it's always more successful. I would never recommend, in the beginning, doing more than 1 to 3 behaviors to target. I've had parents who come in and they've got the right idea, but they've got 10 behaviors that they're working on, and that's too many. So we want to build success. We want things to be easier at first, and then we can increase in complexity and add more expectations in. Taking a first-then approach, first you do your homework, then you get access to screens, then you get to play. We always have to do the non-preferred thing first before the preferred thing, or you're going to have a really hard time transitioning out of that. Spontaneous rewards can be used. So if you see siblings playing together nicely, you can say, oh, you're doing such a great job playing together nicely, and provide a chip, a token, a special reward. This is particularly helpful for children in which you can easily get into a power struggle with. And that have difficulty with compliance. This is a good strategy. Choosing the reward system is really important. So sometimes when I meet with families, I'll spend a whole session on just developing the reward system. Meaning, how many points can they possibly earn each day? Then how many points do you need to get a reward? You have to be really thoughtful about this. Some children need something that day. The younger the child is, the less time that they can go with not getting a reward. Some kids, we hope for in the beginning, about 3 days, 3 to 5 days. Sometimes I'll see parents where it's a month before they get a reward. It's not going to happen. And so then everybody forgets about the system, and then it's just not going to be successful, right? And then the child thinks, well, well, I've already lost my points, I've lost them in the morning, for example, I can't earn them back, kind of what's the point, and loses motivation. So we work on that. And then we also work on developing a rewards menu. So you have to understand and know what motivates the child. So meaning, what does that child really want? We could make a whole list of things. And we want low to no cost rewards, right? Because you don't want everything to be Legos. It just can't be, right? So we help come up with a whole list of things that would be possible options. But for some children who are older, you can't give them a sticker anymore. Like, it just doesn't work. So then you kind of have to think about, okay, so how much money can we spend and what's reasonable? So maybe it's bowling. And maybe it's bowling, and since the child's older, we can go bowling in a week and a half, whatever the case may be. So I figure all this out with the family so they have a concrete system. The parent knows, the child knows. Social and emotional coaching, also very important. So in general, children with ADHD tend to be about 2 to 3 years behind, socially and emotionally. So I often hear parents come in and say, with a child who is 7, this child's having a temper tantrum like a 4-year-old, and is highly concerned about that. And in reality, because of the prefrontal cortex that I was talking about before, where ADHD affects that area of the brain, that's what we'd expect. So the younger the child is, the greater the gap, right? But then when you're like 23 to 21, there's not a difference. And so again, that goes back to kind of how we conceptualize how some no longer have clinical impairment. So what can parents do? They can work on building children's emotional vocabulary. So children should be able to identify particular situations and state how they feel about it. So we want to work on the basic emotions first, just happy, sad, mad, and worried. Those are the 4 that I always first work on. The reason for that is children need to start to learn what are their morning situations. What are the situations in which they get mad? Oftentimes what happens is we all wait to provide coping strategies, kind of cross your fingers and hope, oh, this isn't going to make them mad this time. And then they get mad. And then we try to implement coping strategies when things are already at like 100. So we need to identify these situations early on so we can actually do prevention strategies, right? We know we're 90% likely, or it's 90% likely that this is going to be a problem for the child. Let's implement coping strategies first. Prompting and coaching, social skills like sharing, hands to self, that's really important. So coaching play dates for kids. And certainly modeling positive statements and interactions at home, that's very powerful too. And in older children, we can do collaborative problem solving, meaning we can identify what situations there can be some give and take in, and that is typically helpful. We're trying to do this to help them with self-regulation, so emotional and behavioral regulation. And with social and emotional coaching, persistence coaching and academic coaching is really helpful. Meaning persistence coaching, you're rewarding and praising effort and the process, not necessarily the product, because they're so used to the product, is what's being rewarded. And we just want effort. We want to build this self-esteem. So here's a list of positive discipline strategies. If you go through these steps, some of you may be familiar with Russell Barkley's model. We always start with the positive first. So we always start with the labeled praise, the special playtimes. If you do all of those things in the reinforcement plan, you should spend very little time disciplining. I often find when people come to the office, the first questions they have are, how do I discipline my child? Like, timeout doesn't work. And that's the first thing that they want to address. We know if we address that first, that's not going to be most effective. Because again, how do we positively change behavior? Through rewards and reinforcement. So you're going to get more movement that way. So at this point, if all those other things were addressed, we would just want to encourage effective limit setting. So again, going back to household rules. Providing as much redirection as possible. So you can tell, like, if you're out in public and the child starts to get impulsive, starts to get a little hyper, touching everything. In most children, you can redirect them to something that they enjoy. So if you catch it early, and that's the whole point of trying to catch things early and understanding their signs and when they're starting to get restless. Ignoring. You want to ignore minor misbehavior. Minor misbehavior can be defined differently in different households, but in general, crying, whining, minor name calling, if you address every single thing that happens, then again, you're giving more attention to the negative than to the positive. So then you're starting that whole thing again where the child is just acting out to get negative attention because it's better than no attention at all. So I also would work with families on identifying what can we really ignore. You will find if you ignore something for about 3 weeks in the same exact way and you follow through, it extinguishes the behavior. The behavior goes away. Timeout. Timeout is done differently based on different programs. So there's different recommendations, and I'm sure you've all read different things about timeout. In general, what we would say is you give a warning, like you give a directive, you give 5 seconds for the child to engage in completing the directive. Child doesn't do it, then you give a warning, there's 5 more seconds, and a warning, so you allow 3 warnings, and then it's timeout. Typically they say it's 1 to 2 minutes per year old the child is, and then the child has to have quiet hands, quiet feet, quiet mouth for a few seconds before the child is able to come out of timeout. Some people will say, well, if the child keeps getting out or the child isn't complying with that, they keep restarting the clock. And some theories, some approaches will say up to 30, 40 minutes in timeout. For children with ADHD, that can be really, really tough. And so then we think about other ways to do that, right? And that's when I have to individualize recommendations based on the family and the child. But what you can do is if timeouts aren't effective, because in many families they're not, because of that hyperactivity component, then you can try the timeout, but then you can introduce then a loss of a privilege, right? So you can it can be a phased approach. So that's also something to consider. The response cost procedure, that's related to a token system. A token economy means that you're getting points or rewards for things, and then those points can be taken away if certain behaviors are exhibited, okay? Child has to be old enough to add and subtract to understand that. So that's one thing. And then the second thing is you have to have a reinforcement plan working for several weeks first before you start taking things away. So you've got to build the understanding of what this is and the motivation. Natural and logical consequences. So for example, if you had given the child money because that child earned an allowance and the child spent all the money on candy and then the child sees something else that he or she wants, the natural and logical consequence is you spent all of your money, right? The most important thing is whatever you say, you've got to follow through with. So you really have to think about it because even if like 9 times you followed out of 10, you followed the program, the one time you did it, that child doing something that one time and remembers that one time. We all do. So again, kind of thinking about what you can follow through with and what you're comfortable with. And then certainly removal of privileges, which really put a child to hold for time out. Some children, being 6, 7, then we think about what do we need to remove. Child strategies. So important things that your child, you can help your child do. Self-monitoring and whole body listening. So what I was saying before is we really want that child to be able to match situations with feelings. And that child should be able to go from head to toe and think about what are my eyes doing? Where should my eyes be? What are my ears doing? What is my mouth doing? My hands, my feet, to go through. Because we need to increase awareness in time and space and also increase awareness of the environment. Self-coaching is really important. So internalization of self-thought. Essentially, first I do this, then I do that. Exercise, we know that increases alpha wave activity in the brain. It helps you concentrate more easily. Certainly it releases endorphins, so it increases their sense of well-being. Sleep, mentioned sleep is really important. Social problem solving, you can help children identify a situation, kind of stop. What's the problem? What are the options? Picking an option and helping them evaluate, was that a good solution? And then relaxation and mindfulness. So again, if we break down self-monitoring, these are some of the components. So you need both external awareness of the environment, internal, so how are you feeling, the body scanning, the whole body listening. Time management is super important that we help kids get a sense of how long things take, paying attention to time, and then organization, helping them develop a structured system that's going to work for them at home and at school. You can help the child engage in self-coaching. So narration is so helpful. So again, it promotes that internalization of self-thought. So even when they're playing, they're putting the red block on top of the blue block, and the blue block is going on top of the green block. Just narrating what they're doing, almost like a sports broadcaster, because then that teaches them to slow down when they do tasks and to break it down. And then certainly they need short-term and long-term goals. Relaxation, the three most successful or recommended techniques: diaphragmatic breathing. Diaphragmatic breathing regulates, normalizes heart rate, so there is scientific evidence behind it. Oftentimes, though, it's not done in the correct way, and that's why kids say it doesn't work, because they end up breathing too quickly. Progressive muscle relaxation, visualization of doing something positively and successfully, and then guided imagery, so a calming image in their mind and relaxing. Mindfulness is also used quite often. Mindfulness helps children be more in the present moment and to pay attention to their thoughts, meaning that, I had a thought, but you know what? I'm working on my math homework right now. I'm going to let that thought pass. So really just being focused on the thing they're doing at that time. Really hard. It takes a lot of practice, but that's also a technique that we use. School strategies, use of visuals, very important for younger kids. So helping them to know what comes next. So each component of the day. It also helps with transitions. Use of assignment notebook or Google Classroom is also necessary. And having them take an approach where maybe the system is, as soon as they come home, they check Google Classroom, they check in with you. So this can be individualized and customized based on the child, but they need to have a tracking and checking system. Having step-by-step directions broken down in the classroom can often be very helpful. You know when you give 3 directives at once in the home setting, that maybe one of those things gets done. So we really need to do one thing, come back and check, do the next thing. Channeling the physical energy. Recess is really important, even if there's been behaviors that we wouldn't want to see. It's really helpful. They need to release some of that energy. Creating outlines. Sometimes schools will provide the outlines, like if it's a 504 plan or an IEP, and then the child can just add in some of the notes so they can attend more to the information. Sometimes opportunities to provide information orally is also provided, again, more in a 504 plan, IEP type of situation. Teachers can sometimes give a nonverbal signal or a cue, so when the child is getting off task or starting to play, getting distracted, they have something that they both know. This way other children don't know, so it's discreet, but it reminds the child, I'm off task. Certainly breaks, and then a behavioral plan, similarly to what I previously discussed in terms of a token economy. There are many strengths with children who have ADHD, so they do have a good amount of energy. So that's great, and I often find that they want to try new hobbies and try things, and they're flexible and creative, and they're often enthusiastic to try those things, so that's great. We just channel. And then these are 3 example programs of evidence-based interventions. You can always look it up later, I guess, but triple P, positive parenting, that's for externalizing disorders in ADHD. That's found typically in primary care settings, so that would be something the pediatrician offers or you can inquire about. Incredible Years parenting program, there's a ton of information online about that. That's typically in a group setting for parents. Both are focused on parent training. Incredible Years goes through the steps that I described in terms of special time, reinforcement, ignoring minor misbehavior, consequences. And then parent-child interaction therapy is one-on-one therapy where it's rooted in providing special time. So it's, you go to the therapist does a 5-minute observation of you interacting with the child, makes notes, and then it focuses on the prize skills. So it's teaching parents how to give labeled praise, reflect back appropriately what's being said, imitating the behavior, describing the behavior, back to self-coaching, and then using enthusiasm. And then once a certain level is achieved, then there starts to be the parent-directed piece, where you learn how to give commands and directives. Okay, very quickly, and this is the last thing. Problem-solving challenges. So here's a list of the most common challenges that parents come to me with. So that are easy fixes, right? So the first one is unrealistic expectations. We know that a typically developing child without any diagnoses will not follow directives 35% of the time. Okay, so we have to go in with realistic expectations. And giving 2 or 3 prompts for a child who has ADHD is okay. So we would help identify what's realistic. Waiting too long to reinforce, I referred to that before, that's really challenging because then we lose sight of, it seems so far away that that's hard. I've also seen situations in which the child has been good, and then has one rough day, and the parents will say, nope, then you lost it. And so even though the child had earned it, they lose it that same day that they're supposed to get the reward. Rewarding almost behaviors, then you're getting farther and farther away from the goal, from the target. Unlimited access to the reinforcer. If the reinforcer is electronics and the child in his or her free time always has access to electronics, that's not going to be motivating. An unclear system, so not knowing when they're going to be rewarded or disciplined, lack of follow-through, using loss of rewards as a punishment, so it shouldn't work like that, and fighting every battle, meaning not ignoring the small stuff.
At this point, we open up the room for questions from the parents.
So one question is strategies for bedtime. So I'm assuming that the child's hyper or impulsive or does not want to go to bed. That could be one challenge. For those challenges, if it's presenting like that, then you can implement like going to bed without tantruming or going to bed at X time as part of the rewards or reinforcement system. If the child's having difficulty calming his or her body, then you really want to work on relaxation strategies. So the diaphragmatic breathing, progressive muscle relaxation, so for calming strategies. There could be a lot of different bedtime issues. Also, getting out of bed in the middle of the night, like there's many. In general, that's how you address it. If the child's getting out of bed multiple times in the middle of the night, then you do what we call provide bedtime passes, which is also a reward system. First question with this part is understanding the difference between testing for ADHD and autism spectrum disorder. So an ADHD diagnosis can be made by going to the pediatrician and completing Vanderbilt scales. So there's a parent and teacher questionnaire. So it could be as, quote unquote, as simple as that. Going to the pediatrician, completing questionnaires. When you're diagnosing autism, that involves typically a couple things. One is an evaluation by a developmental behavioral pediatrician, or 2, an evaluation by a clinical psychologist or neuropsychologist. And that can involve pretty extensive testing. So it could involve cognitive achievement testing. Typically what we need now is the ADOS. Maybe some of you have heard of it. It's a play-based intervention. That's the gold standard to determine if the child has autism. It's one feature that helps us to determine it. And then certainly parent and teacher questionnaires need to be completed. So the autism evaluation is much more extensive, and you have to go to a specialist who can provide that diagnosis. So that's lots of testing. And how it's different. So kids with ADHD may have social and emotional difficulties, right? We said 2 to 3 years behind for some children. And they want to have friendships. They're typically very interactive kids. And they can have reciprocal conversations with you, meaning you have that back and forth. They'll talk to you about tons of things. But it's more the deficit or the area of difficulty is understanding boundaries and understanding maybe when a friend is getting overwhelmed or they've provided too much information and they've talked excessively and picking up on those types of cues. Children who have autism in general tend to not have as much of a desire to interact with other people. Like they're fine playing by themselves. The other piece is you don't get that reciprocity. So you don't get that back and forth nature in conversation, or it's very limited if that occurs. And then you also have eye contact that's not being made. There are other things that go along with it, but those would be the general differentiating features in terms of social skills.
How should I approach the school about a child who does well at school but then explodes at home? This is a very common one.
I know. Well, that can be challenging because the school is really only responsible for the child's time at school. So in my experience, so anecdotally, if there aren't problems in the classroom, then they really don't have anything to work with. So they don't have the ABCs, the antecedents, behaviors, and consequences. So they wouldn't even know how to address that. If it's around homework or something that's academic, that once they get home, then they refuse to complete homework or something like that, then that would be an area to engage the school so they understand the challenges. And maybe there's some natural logical consequences for the child, but that would be more related to the parent training. So working with somebody to figure out the function of the behavior, why is homework so challenging, and to come up with a plan.
Can you explain ODD a bit more?
Sure. So ODD stands for Oppositional Defiant Disorder, and it's a behavioral disorder. So what that means is they call it a learned disorder, and so the good part is because it's a learned disorder, that means it can be unlearned. So through behavioral strategies, that can be changed. Where ADHD is neurodevelopmental. So difficulty sustaining attention and maybe the hyperactivity, impulsivity will be there. It's just channeling it and managing it in a different way. So we tend to think that oppositional behavior is not following directives, not complying with authority. It's more of a willful thing, more argumentative behavior. It doesn't have to be present in both settings. So sometimes I have patients who are just super oppositional at home, but compliant at school, or vice versa. But then we want to explore what's different between those two environments, what's kind of triggering those behaviors.
This next one has to do more with how do you know when the behaviors are enough to merit going to see either a pediatric neurologist, a psychologist, to kind of start the diagnosis process.
Okay. So the first step, I would say, most commonly, is having a discussion with the pediatrician and talking about what type of behaviors you're seeing and is that developmentally appropriate. So obviously a 4-year-old, there's more room there for being hyper and impulsive, but still being within that normative range. When you're talking about a 12-year-old that can't stay seated at a desk, then that looks different. So that would be the first place that I would start, is talking to the pediatrician about that. And then the pediatricians are typically very good at saying, okay, well, I think then it's time for a more extensive evaluation or a referral to a behavior specialist or to a psychologist. Sometimes pediatricians feel comfortable treating ADHD, meaning giving out the questionnaires and also providing medication management. So there's different pathways to getting the diagnosis. What I would say is, from a psychologist standpoint, if you really need help with that behavioral plan, like you feel that you've tried behavioral strategies, you've read Russell Barkley's books, for example, Taking Charge of ADHD, and you've done those things, and it's still a struggle, then probably having a consultation with a psychologist would be helpful to shape up your plan, just to help problem solve where are the difficulties and what might be going wrong.
And if you are diagnosed and you want to begin some sort of behavior therapy, do health insurances cover this?
Yes. So like parent training and behavior management is billed under the child insurance. So it's not the parents' insurance. Yeah. But it varies again about how much is covered and how many sessions.
Can you outgrow ADHD?
No. So about 30%, like 30 to 50%, will still meet that criteria in adulthood. We know that. But it's that they don't have that clinical impairment anymore. It didn't go away in the other percentages. It's just that they've learned strategies to organize. So they use calendars. They use all of those things. They know where their areas of difficulty are, and they make modifications for that. just as normal development, hyperactivity and impulsivity will decrease just as children get older. So, a 7-year-old is going to be more hyperactive and impulsive with ADHD than a 15-year-old. So naturally, it just decreases with age, but then, so what you're left with more as an adult, an untreated adult, would be inattention and restlessness. So maybe we tend to find that we naturally gravitate toward jobs that fit our personality. So, for example, that probably wouldn't be someone that wants to sit at a desk all day. Maybe they would be good at doing sales or going in different places. So that's where that impairment tends to decrease.
So a question about impulsivity and dangerous impulsivity behavior. So what kinds of things can you do when you obviously can't ignore impulsive running? How do you help them when they feel like they can't control those more dangerous behaviors?
With dangerous behaviors, like darting into the street and things of that nature, that tends to go hand in hand typically with kids who have more severe ADHD, and that's when I tend to talk with families about medication and a referral either through pediatrician, psychiatry, or developmental behavioral pediatrician, because safety is the biggest concern. So if we can't maintain safety through reinforcement plans, like, okay, you have to hold my hand when we're walking through the parking lot, and that just doesn't work, and the child's like running off, and then that's when we start to think about some of those other options to keep the child safe.
Any recommendations for different standards for each child? So for instance, if one child has ADHD but excels at school and one child has ADHD but struggles, how do you treat both children and respect their differences?
Okay. So children who have ADHD, like predominantly inattentive type, for example, or just inattentive, then typically we don't see that there's behavioral problems like at home. So, again, that's the only diagnosis we have. So then what we would do is just focus more on the organizational aspect, the executive functioning. Executive functioning means one's ability to plan, to reason, to organize. So then, we would work with you as a parent, work with a child on, further developing those skills tailored to the child's age. If the child is doing well in school and there are no problems at school, then we would just work on parent training and talking about the behaviors at home. If the child is having difficulties at school academically, then psychologists, therapists often partner with the schools and talk about what their observations are, the ABCs that the parent has given them. So then there's some coordination of care between the school and the therapist typically, if the school is open to that. If there are problems in the school setting. And sometimes we also, as clinical psychologists, neuropsychologists, can complete learning disorder evaluations or certainly encourage the school to complete those evaluations if there are learning concerns.
So another kind of combo between a child with autism and ADHD, and within the school setting, the child is in advanced classes, the child is struggling. So is it better to keep the child challenged or move them down to average level classes? So again, that kind of inability to regulate but being quite bright.
Yeah. So I would typically ask a lot more questions to help determine, to give a recommendation. In general, though, I don't know if this applies specifically, I don't know if this would be the recommendation I would give to you if I was seeing you and had all the information, but in general, we would say that you need to emotionally and behaviorally figure out that regulation piece before we continue to advance in classes, particularly as the child gets older, because then what happens is we're getting a greater and greater gap. And then what I've seen is then children start to have emotional meltdowns and can't regulate in school in some of these gifted classes, because eventually things do just get more challenging. Not that they're not bright enough, but it takes more perseverance. It's more things that maybe they're not interested in. And then once we start to have emotional outbursts at school, then that's something that's really hard to undo and to create a plan around.
Okay, so this next one is kind of similar to the dangerous behavior question. They're calling it drive-by impulsive behaviors, which I've seen a lot of. So how do you help control those how do you help guide those children when there's not even enough time to do the reinforcing, when it's just moving from one thing to the next, flipping toys, dumping things, high energy ADHD children?
Yes. So from my standpoint, what I would do is work on prevention strategies and look for modifications that we can make to the environment. So like kids who they play with every single toy, move from thing to thing to thing, then, for example, you have one toy that's out. That's it. We've got to slow that child down. And so then that's where narration and descriptive commenting really helps. Is it going to work the first time? It's something that you've got to build a skill in that child. So I would look for prevention strategies and then environmental modifications. In terms of prevention strategies, scheduling breaks throughout the day where you're already trying to keep the child in a calming place, it's likely that things have built up during the day that we're not even aware of that have increased and contributed to increased hyperactivity and impulsivity. But again, then I would consider medication, because sometimes, as we've seen in the MTA study, medication, if we're looking at medication or behavioral therapy, medication, does outperform behavioral therapy. So in some cases, we really need that medication to help that child stop, think, and make good choices.
So jumping on that medication, there we have, and I know you're not a prescriber,
Yes.
but there does seem to be a few questions that have to do with kind of fear of medication, when to know you need to medicate, and fear of once you start medication, will your child ever be able to come off of the medication? So I don't know how much of that you feel like you can address, but whatever you can.
Sure. So related to the fear of medication, all I can do is speak to the patients that I see, and by and large, the number that have found improvements and their lives are better and more positive as a result of medication far outweighs any side effect that I've had patients complain about. So that's all I can kind of say is anecdotally, it has made a huge difference for the vast majority of children that I see, both in terms of academic performance, so they're able to concentrate better, they're not being removed from the classroom, so their grades have improved, their interactions with peers is better. So I would say that. If you have any fears or concerns, certainly, going for a medication evaluation by a psychiatrist, developmental behavioral pediatrician, or regular pediatrician doesn't mean that you have to do it. I always think it's better to have the information, all the information. So I do recommend to families that you're kind of on the fence, please go and get the information, and then you can decide what to do from there.
So how do you handle tantrums or behaviors when the child is maybe too young or developmentally too young to understand the whys that you're giving them? So the verbal explanations, the verbal ABCs may not be developmentally appropriate for them.
Okay, so what we would do is figure out, from a parent's perspective, what situations are they most likely to tantrum in. And you can 90% of the time find patterns. It just doesn't come, out of nowhere. And so then what we would do is, again, do environmental modification. The more talking you do to kids when they're upset, the more upset that makes them. They don't hear any of it. And they just get, it just becomes so overwhelming. And then usually the behavior intensifies. So the best thing to do is, one, identify the patterns. Two, set expectations of, like when the child is calm. Hey, I know sometimes going into the store is kind of hard for you. Or I know going to the library, sometimes it's hard to be quiet. Set certain expectations, and then you can combine that, again, with the reinforcer. And I keep talking about reinforcers, and praise, that is so important, and it really is the best tool out of these behavioral strategies to change behaviors.
What is the best approach for dealing with hyperactive behaviors or impulsive behaviors during an extracurricular activity? So for instance, during a soccer game or during organizing sport?
So one, I would want to know, does the child really want to do the activity? Because that's a real important factor. Sometimes it's just not a good match. So oftentimes, for example, a parent, the child will say, I want to do baseball, for example, and the parent enrolls the child in baseball. Well, baseball is like one of the sports that's really hard to do if you have ADHD. So it's also being mindful about matching the child with the right activity, like from the parent's perspective at the outset before enrolling in something and trying it out. The other thing would be, of course, depending upon the age, but taking that child aside and providing that coaching of, again, what's expected in the environment, practicing at home. You could use a cue between the child and the coach, but so much of it, again, depends on what the activity is, and is it necessary, and is the child enjoying it, and can there be coaching?
So this is, I think, more asking about, so if there are parents that are divorced or are not cohabitating, should the parents attend therapy together for the child?
So what I would say is it's good to be on the same page. So we know that we've got more success if everyone is using the same behavioral plan. Can two people sometimes be in the same room and get that happening? Sometimes that can't happen. Sometimes it can. So if it can and there's an amicable relationship, I always think that's the best way to go. Sometimes I hear, though, that behaviors are different in different homes. Like, oh, that's not a problem ever in my home. So then what I'll do is sometimes meet with the parents individually and figure out, again, the ABC. So what's different about the two settings and how that child is responding to those two settings. And even if we don't have the same behavioral plans, because there are different presenting concerns, in the different homes we have the same approach, by having behaviors to reward, ignore, which should receive consequences, and what are the consequences. So having everybody on the same page or on board is really important and helpful.
A parent asks why some providers don't want to diagnose certain conditions until 6 and over.
So a lot of agencies don't provide mental health services until about 5 or 6. So that, if your child is younger, you have to ask, because some don't provide early intervention services. So that's one thing. But the primary reason is because that's still that developmental phase. And so a lot of people are hesitant to say, yeah, that kid does have a neurodevelopmental disorder that's going to be with him or her for our whole life, because there's still a lot of growing and learning to do, and people can do that at different rates. So usually, unless it's severe ADHD, we're thinking about like entry into school.